Hi, I'm Kevin Winthrop from Oregon Health Science University in Portland, Oregon, and I just had the luxury to be with Dr. Jack Cush in room now here at ULAR, where I gave a hot session on how to risk, stratify, and prevent infectious diseases in patients on DMARD therapy. I wanted to highlight a couple things I just were asked by the audience afterwards. I think I had about 28 questions, and half of them were on tuberculosis. Many of the people here obviously treat patients who are living in endemic areas for TB, and screening is of high importance. Screening paradigms here are just the same as they are at home in the US, but a little bit different, and I highlighted three things. One question that was repeatedly asked was, I've screened someone, they've been treated for LTBI before, how do I handle screening them in the future? And the answer is, you don't. You can't screen them. Their tests will probably stay positive if they were positive before, so there's no need to repeat them. But taking risk factors or taking a history of potential exposure is important. And certainly if someone's been exposed, a chest x-ray and thinking about retreatment is something that could occur, but it is a rare event. Second question, people who've been screened negative for years, they keep getting screened every year, every time they switch a biologic. Do we need to do that? The answer is, at least in the US, no. Really, re-screening individuals is only necessary if they have a risk for exposure. So in low endemic areas like the US, it's really not something we need to do. I know the payer sometimes makes you do it, but CDC and other TB authorities would recommend repeating it unless there's a risk of exposure. The third question had to do with treatment of latent TB infection. One gentleman mentioned the high isoniazid resistant rates in the country he comes from. And in fact, that is true. We, as a group or as a specialty, have been moving away from using INH, not necessarily due to the resistance issue, but more due to the completion rates of a 9-month treatment period. Completion rates are low, and it's, of course, carries risk with hepatotoxicity, and sometimes patients just don't want to take that drug. So we have drifted towards using rifampin-based regimens. And the regimen I'd like to highlight is the preferred regimen, at least in the eyes of the CDC in the US, and that's once weekly isoniazid and rifapentine, and it's only for 12 weeks. So the completion rates are high, the efficacy is better than 9 months of INH, and that is probably your number one regimen to go with today. So I hope that's it. Thanks very much for listening, and thanks to Dr. Cush for being here.